Chapter 26. In this chapter, we're going to be talking about epidemiology. How do we collect data and track how infectious diseases are spreading through populations? Our higher order learning outcomes for this chapter are to be able to think about data and use data to answer questions about incidence and prevalence and help think about why and how we can find that index case of an outbreak. Number 2 of our higher order learning outcomes is to be able to use the concepts we've learned to describe an outbreak. We've talked already a lot in previous chapters about how people get sick, how diseases are transmitted, what signs and symptoms we need to watch for. So we're going to put all of that into practice as we think about how epidemiologists go about their work. In our opening case, in May of 2011, we have people in Germany starting to die from E. coli, a strain of E. coli that has the Shiga toxin, which causes hemolytic uremic syndrome. By June of that month, there had been 3,000 cases of this disease and 35 deaths. So they immediately started doing some diagnostic testing and finding samples of this particular E. coli bacteria. People with this infection get very, very sick, and some can go into kidney failure. So this can be a really deadly complication. What they found was that in early June, Germany blamed Spain for producing cucumbers that had caused this outbreak, so contaminated cucumbers. Later evidence, as they kept collecting more and more data and looking at more and more samples, showed that Spain was actually not the source of this organism, that it was the agricultural ministry of Lower Saxony, that an organic farmer near Uelzen that produced sprouted foods was likely the source. So before the source was found, several tourists in Germany ingested the organism and returned to their home countries in the United States and Canada, where they also got sick. So trying to find the source of an outbreak can be very difficult, especially in an area where food is transported across borders really quickly. Oftentimes our typical salad that we might have at the salad bar may have come from 5, 6, 7 different countries. So trying to track down what food product made people sick and where that food product came from can be really tricky. And the work of epidemiologists are the ones doing this. So when we think about all the things that we have to keep track of are what kinds of factors the organism has, whether it has virulence factors or how invasive it is, what reservoirs we need to test, how the organism is transmitted, and who might be exposed. So when we think about an outbreak, we have to think about all of these different aspects to make sure that we're kind of covering our bases. Now, we have a history lesson here about some historical epidemiologists and some early epidemiology that was done. This particular picture is of John Snow, who used data that was being collected to stop a cholera outbreak in 1854. Now, this sort of brings up the point of what kind of data do epidemiologists collect? So in descriptive epidemiology, which is one of the types, they're really just reporting and describing all of the data that they have. So they want to know how many people are sick with what. So the CDC every week, puts out a report called the Morbidity and Mortality Weekly Report, and it describes all of the different infectious diseases and where they've occurred that week. So there's a number of reportable illnesses that we describe and talk about and collect data on. And that data just sort of sits there. It can be organized by geography. It could be organized by region of the country. It could be organized by age group, who's getting sick with the particular pathogens. In the case of John Snow, an early example of this kind of descriptive epidemiology, he made a map of where everybody was sick and how many people got sick. And he realized that all the people that got sick, all these little bars on his graph, all were centered around this one water pump. And so he began to make a hypothesis about his data, which is that leap from descriptive epidemiology into analytical or experimental epidemiology. In analytical epidemiology, we look at the data, we've described the data. So in this case, that would be the map where he made all of the different marks here. And now we're going to come up with a hypothesis. I hypothesize that that water pump in the middle of this map is the one that's causing people to be sick. And so he might run an experiment, he might go test the pump water, and sure enough, that's what happened. And he could figure out that cholera was being transmitted through the water in this particular neighborhood. So we do these two kinds of epidemiology all the time. And sometimes we describe the data, we collect that descriptive epidemiology, and nothing really happens with it. So we have all this data sort of collected, and it can be used for all kinds of purposes, but it may not be collected with the intention of doing an experiment. And then we have analytical and experimental epidemiology, where we're asking a question. We come with a hypothesis to ask a question about that data. What is the cause of this outbreak? Or are more people sick that are vaccinated versus unvaccinated, for example? So there's lots of different ways that we can use this kind of data. Another set of terms that we need to pay attention to are the terms endemic and epidemic. So endemic diseases are low-level cases that sort of maybe fluctuate a little bit, but are sort of always present in the population. So for example, the common cold is a great example of something that's endemic. At some point, somewhere, somebody has the cold, right? So there's always these low cases. There may be seasonal, blurps where people get a little bit more sick than others, but it's not sort of something that would make the news. We're not going to hear about the number of common cold cases in the news. Now, an epidemic is a shorter period of time with an extraordinarily large number of cases. So an epidemic here, we can see, is going to be much, much more intense, or large numbers of cases over an endemic. And it's definitely going to be something that makes the news. Now, another term that we have used previously and had a lot more weight previously was the term pandemic. A pandemic is an epidemic that has occurred on more than one continent. Well, with the advent of international flights, an epidemic can literally become a pandemic in one day. So the word pandemic isn't as valuable a term as it used to be when travel was much more difficult. So a pandemic used to be much, much more serious. Nowadays, it's much more common to see an epidemic become a pandemic pretty regularly. So here is an example of the avian flu that is now pretty much endemic in Asia, but it can sometimes cause epidemics or outbreaks in other parts of the country. Okay, so the next set of terms that we think about with epidemiology are the terms incidence and prevalence. So incidence and prevalence are really thinking about the new cases. So this map shows the disease incidence. How many new cases of, in this case, Lyme disease are occurring in 2012, right? So this is 1 year, and we want to know how many new cases there are. So incidence are the number of new cases that are happening. Prevalence are the number of cases that are present in the population totally. So if these are the cases that happened in 2012, how many people were already infected with Lyme disease, or how many people have Lyme disease since 2012? That would be sort of the prevalence of Lyme disease. And that might be a different map. So it might have a lot more dots, right? So typically prevalence, in most cases, there's more people that have it than the incidence of the new case in that one time period that we're talking about. In most of the time, a disease that people get better from or heal from, the incidence will go down after the outbreak happens, or the prevalence will go down after people get better. In some cases, however, the prevalence never goes down. So in the case of HIV infection, which HIV is a latent cycle virus, and so it is always incorporated into our genome. So people that get HIV always have HIV. In that case, the prevalence keeps rising. People will die from HIV, but as many people keep getting infected, less people die than get infected new, and so the prevalence keeps rising. So the numbers don't ever sort of go down, and we think about a single population there, unless somebody has died. Here's another example of the incidence of syphilis in 2012. So here we kind of just see another representation for how that data can be shown. And again, this is the number of new cases of syphilis in 1 year. Okay. Another look at data that we might consider here is the incidence of measles, right? So we can look at the incidence of measles on year. We can see that they had steadily decreased with the advent of the measles vaccine in 1977. We pretty much had gotten rid of most of it. There was an outbreak scare in the early 90s, and then we've pretty much gone down since then. We have in the past few years, however, so from here, if we zoom in on this incidence level, we can see that there have been some peaks due to vaccine noncompliance. So we can monitor whether vaccines are working by looking at the incidence or number of new cases of a pathogen in the population. Okay. So let's look at nosocomial infections. So nosocomial infections are hospital-acquired infections. And we start by thinking of a case history here. So we have Stephanie, who is a bright 7-year-old girl who came to a Canadian hospital for a tonsillectomy. So she was healthy. She might have had some strep throat problems or throat problems in the past, and she was coming to get her tonsils out. Her mom was there, and she was doing okay. She, came through surgery just fine. However, after the surgery, that night, her fever had risen to 102 degrees. By the next day, Stephanie's heart was racing and her breathing was labored. She was rushed to the ICU. Stephanie was diagnosed with post-surgical sepsis. So she did not have an infection when she came to the hospital. And as a result of being in that clinical setting, she did acquire this infection. Unfortunately, Stephanie died, and it turned out that the organism they isolated from her blood was MRSA, a Staph aureus strain that had been the cause of a wound infection in a person on the same floor. So nosocomial infections are infections we acquire in clinical settings, and they oftentimes are the result of patient care providers back and forth. Now, things that we cannot control, so we can't just make hospitals only for people that are healthy, right? That's the opposite purpose of a hospital. So people in hospitals or clinical settings are going to bring a lot of different kinds of infectious pathogens with them. They also tend to have a compromised immune system. So patients, when they come to the clinic, even if they're healthy when they come, like this young girl we're talking about here, as soon as she had surgery, she had a compromised immune system. Or people come in with a compromised immune system. So it's sort of this perfect storm. There's also a chain of transmission. So nurses, unfortunately, in our country don't get to just have one patient. They often have many patients, and they work in communal workspaces. So there's an opportunity for these infectious pathogens to be exposed to people that are compromised, and those chains of transmission, the people that are interacting with all those patients, oftentimes go from patient to patient. So most of the time we talk about preventing these kinds of infections. We think about proper hand washing technique. We think about wiping down and disinfecting surfaces, making sure to clean rooms and ventilate the air properly. All of those things are important when trying to prevent a nosocomial infection. The most common or typical nosocomial infections, the most common one, are typically urinary tract infections. So about 50% of infections are caused by a urinary tract. And so any kind of equipment that might be used in a hospital setting, or in the case of an intravenous catheter here, or a indwelling catheter like a urinary catheter, we see those as opportunities for bacteria to be introduced or to travel along that catheter and make somebody sick. So in the case of UTIs or urinary tract infections, it's most often catheters that cause the infection. Pneumonia can occur in people on ventilators or on oxygen where there's forced air being put into the lungs. Surgical wounds, obviously those can be really important. In this case, this was a surgical wound that caused this young woman to die. Septicemia, which is the intravenous catheters, can be a risk factor for that. And then diarrhea. So we think about pathogens like C. diff, which thrives in environments where people are taking a lot of antibiotics. Well, in hospitals, there's a lot of people that take antibiotics. So patients are more susceptible to catching Clostridium difficile or C. diff in those situations. Now, how do we identify the source, right? So in these situations, we have to really keep track of that chain of transmission. So is each patient infected with the identical isolate? So this goes back to our discussions of chapter 25, why it can be really important to make sure that the same pathogen is making somebody sick. Also, has any member of the hospital staff made contact with all of the patients? So if 5 people acquire a UTI on the same floor, did they all have the same nurse, or did they all use the same technician, or the doctor visit all of them? Did all patients come in contact with the same medical instrument? So again, looking at respirators and ventilators, looking at catheters and IV tubes, food and water vessels can be important. Were the affected patients in contact with each other? So is there some way that, did they share a room? Did they share the ICU? Did they share a recovery space? And then thinking about, of course, if the infectious agent is airborne, what proper procedures do we have to clean the air? Are there filters on the air? Are there ultraviolet lights? Making sure that everybody is washing their hands properly, changing their scrubs when they're dirty, making sure to wear gloves properly. All of those kinds of things can be really important in preventing those nosocomial infections. All right. So there's our typical nosocomial infections. Here's somebody using proper technique to make sure those hand sanitizers are used properly before going into each and every hospital room. Making sure we wear proper protective equipment, like gloves and gowns when necessary, and making sure that when we put in catheters and draw blood, that we think about those as opportunities for infection to be introduced, and make sure that we always follow the proper procedures for that. Okay. So here is an example of a daisy chain movement, so people getting sick. And we want to know, how do we go from realizing that we have all of these cases back to finding that index case? So in 26.3, we're really thinking about finding that patient 0, or that index case. That is the person that started the infection. And it can be really important to find that person, because that may be the opportunity to see where from the environment the patient encountered it. So it could be an animal, it could be something in a food source, it could be something in a water source, it could be a brand new pathogen that may have emerged by jumping from one species to the next. So finding that index case can be really important in stopping the outbreak from happening, making sure that if there was a breakdown in nursing care, for example, that particular nurse gets more training and has an opportunity to do a better job in the future to prevent future outbreaks. When any of the pathogens on this particular list are detected, they are reported to the CDC, and this is one of the lists of pathogens that we get that Morbidity and Mortality Weekly report from. So we get this report back of all the different cases, the number of cases for each of these pathogens each week. Okay. So let's talk. So here again is another map sort of illustrating that index case. So here are the index cases illustrated in number 1, the very first case, and that person made all of these people sick. In this case, number 1 made number 6 sick. Number 6 then made all of these other people sick, and you can kind of see it's really important to do this kind of mapping to find out what the source is and be able to stop future outbreaks. Okay, so let's look at the effect of climate change on emerging infections. So there's lots of different kinds of emerging infections, and there's lots of different reasons why we see these kinds of infections emerging. One of the things that we need to be mindful of as the climate changes is what kinds of public health situations do we need to be aware of. So with different kinds of climates, we'll have different kinds of weather disasters. So we might have increased numbers of hurricanes in parts of the world. We might have more tornadoes. And all those things bring water and the potential to cause flooding. In case of hurricanes, that's pretty apparent, especially recently. So whenever we have an increased water or flooding risk, we're going to have increased waterborne illnesses. And in warming climates, we'll see new plants and animal species being present. And along with those come all the insects and all the different vectors. So as climate shifts and changes, we're going to see different animals causing infections. We're going to see different insects causing infections. So strains of mosquitoes that we don't normally see in Kansas, for example, we may start seeing. And with those come all of the different kinds of infectious pathogens that they have. Thinking as well about areas that might become more dry as things warm up and water moves elsewhere on the planet. There might be increased risk of aerosolized dusty pathogens. So pathogens like tuberculosis or pathogens like hantavirus that are transmitted by those dust particles can become more of a problem in drier climates. So shifting and changing. If we look at a map here, let's fast forward here to this map. Here are a number of examples of emerging pathogens, and we can start seeing how shifting climates might actually start to shift those pathogens as well. So things that might have been frozen in lakes are now going to be re-exposed to these different places in the planet. We might be seeing pathogens come back that we haven't seen for a while as well. Okay, so the climate can have a really important role in causing new infections to spread and going different places. The last topic that we want to talk about is, let's see, we can start here. The use of select agents. So select agents are agents that can be used as a bioweapon or for biowarfare. This is a mugshot of Rajneesh, who in 1985 tried to cause a bioterror attack. Right, so he tried to use salmonella to make people sick at these particular chains. So he introduced the salmonella at a number of different people, in a number of different food restaurants, and ended up making 700 people sick with salmonella. We also can see situations where there's been scares on anthrax attacks. So here are two people cleaning up and monitoring situations near Capitol Hill during the anthrax attack of 2001. So what is it that makes something an effective bioweapon? The properties that we need to be mindful of are thinking about whether or not the pathogen is contagious, whether it can be aerosolized or delivered easily, and also whether or not the population that it's being delivered to has natural immunity. So if we are not going to get sick with it because we have a vaccine for it or we're just naturally immune, it's not going to be an effective select agent. So those are the things that we have to think about when we talk about which pathogens can be select agents. A short list of those, right? So some that we've already mentioned, smallpox, anthrax. Francisella tularensis is actually one of the ones on the agents list because of those features we just talked about. It can be very contagious, it can be delivered aerosol, and it can, we have no natural immunity for it. It's not something that we tend to see very often. So Yersinia pestis is another one on the list. So when we think about select agents, we need to be mindful that, again, those monitoring systems that we have are designed to detect them. Using the tools of epidemiology, we need to be able to find who that index case was and being able to monitor and figure out how to stop such an outbreak. Hopefully one of these select agents doesn't get released, but the epidemiologists and public health workers in this country are well equipped to handle it if it does happen. Okay, so that is the end of chapter 26, really thinking about how do we collect data about outbreaks, how do we monitor to make sure that there's no epidemics happening or pandemics happening, and how can we be prepared for the changing climate and possible use of select agents.